All right, just to finish up, um, I'll try to run through these pretty quickly, but some of it's a little complex, so I'll try to hit the points that really make the biggest difference. Make sure that you really listen also to the tapes related to the um, exam guide for exam 4, and I'll try to hit some of those hot points again so that you're familiar. Um, Key things to really know about is, what kinds of diet restrictions do these patients have. They may be ordered on fluid restrictions because they're fluid overloaded, which is hard to maintain. You want to just not take a picture in these patients' room. They're going to want, unfortunately, a lot of times they're going to ask you for sodas instead of water to drink, and so that they can't always have that because it puts them over on their 2-gram sodium diet. They need a low protein diet because they already have, uremia, and they don't want to add to that. Um, they may have symptoms of uremic frost and skin issues. They have muscle strength issues, so they're very weak, low energy. They don't want to move. So really trying to turn and position them, keep them off of skin. They may have this excess fluid volume. They may have weeping of their skin because there's so much fluid volume. Thus, another point of risk of infection, skin breakdown. Decreased cardiac output, so you may see them have, lower blood pressures. They can get unstable, and we'll talk about that and how dialysis affects that. They may be ordered on erythropoietin injections, and the goal with that, of course, is to boost up the EPO, and then thus create the situation where their bone marrow is producing more red blood cells and hemoglobin. And this type of patient really has to be managed by a whole team. They may have respiratory treating them. They may have the wound nurse treating them. They may have many family members and different entities in the hospital and outside the hospital that are managing them, from discharge planning, social work, how to get them set up for outpatient hemodialysis treatments, and how do they get transportation to that if they don't live close. And there's just huge issues with managing these patients. They may be managed by a hospitalist and then have a kidney doctor, or a nephrologist be the one who consults and manages the dialysis only, or they may be admitted to the dialysis doctor and then other doctors consulting. So it's a huge team of people, along with nursing. Physical therapy may be involved as well to kind of help with keeping them more active. Make sure that you review this in its entirety. I'm not going to read it to you, but this concept map is really, really good. It gives you a lot of the typical interventions that need to be taken, many of which are things and items that you will get tested on. So pay a lot of attention to what are the key things that you would do for these patients, what are the risk factors for these patients, what conditions that this patient may have been on that could have led to kidney disease. And then last of all, please note that the primary goal or expected outcome, remember we talked about goals and outcomes, first thing on the list is to achieve an acceptable fluid balance. So, what is fluid balance? It is, intake and output that are equal and balanced, right? So strict INOs have got to be maintained on these patients. And if you're achieving that acceptable fluid balance, then you're not getting into all the symptoms of fluid overload. So just know that is one primary goal that you're going to always assess along with your daily labs every day, is what is the fluid balance. And so, Was it even? Are they in overload? What's the status? And then from there, look at what else needs to be treated. Some patients are going to be selected to be on hemodialysis as a treatment. There are going to be set dialysis settings. If these are on in a patient room, some places you will take your patient to a hemodialysis unit where they'll get treated and stay for a few hours and then come back. They may also go down for procedures like to have a catheter placed or to have an AV fistula placed surgically. When hemodialysis is going, if it is where the dialysis nurse comes and brings a dialysis machine to the bedside, in that condition, they are the ones who are primary responsibility for everything related to those settings and management of that patient. It is not advisable for them to leave the room. And if you are the dialysis nurse, you have to stay in constant care of that patient because you are the specialist and you are the one who is trained on maintaining the dialysis treatment, not other nurses that are not trained but providing care on the floor. So key things there. Lastly, anticoagulation is part of what is needed during the procedure itself. So they are going to be receiving a fair amount of heparin, and so you want to watch for considerations for that. Post the treatment, if they're off your floor and they come back, are they having any signs and symptoms of bleeding, and what might you need to be prepared for to provide medications to them, if they're too anticoagulated. These are just some examples of subclavian dialysis catheters. The ones on the top in picture A are short-term catheters. The ones in the bottom, on the bottom picture B, is a perm cath, and you see those fairly frequently. Just know that these are central catheters, just like any other catheters. They have to be placed usually under fluoroscopy to make sure that they're in the correct location, and they have to be sterile, all the things that you typically do. The key aspect of this is that as a typical adult health floor nurse or med-surg nurse, you are not going to touch these. You may do a dressing change because that's needed because it's sterile and it's come loose, and the dialysis nurses are not going to come do that. But we don't, as floor nurses, you don't touch these, you don't use these to give meds through. You may be asked to flush one daily if they're not for a treatment that day, and that would be with a Heplock solution. But other than that, they are only and solely used for the treatment. They're high risk for infection, they're high risk for getting clotted off, and so on the floor, the dialysis team doesn't want us to touch them. So just know that those are many of the restrictions related to it. You notice they look different because they have a red and a blue port, meaning there's an arterial and a venous port associated with them. So that gives you an idea that they're just not for typical use as well. This is what a hemodialysis circuit, review this in your book so that you really understand how dialysate creates kind of a gradient for these electrolytes and solutes and materials that would normally be excreted through the urine. This dialysate solution is usually heated a little bit for this during this procedure, so it's not uncommon for somebody to come back post dialysis and have a low-grade fever. That is not necessarily a huge sign of infection, but you do want to know that could be a potential cause. And then Knowing that this stuff runs very slowly because it's really based on a pressure gradient for these solutes to move and be pulled out of the bloodstream. And so patients may be on this treatment for, 2 to 4 hours 3 times a day. The other consideration is think about how much blood cells through this process going in and out and being cleansed may be destroyed. They're already in a situation where they have anemia, but this can add to it because of that. So what's going out may not be the same amount coming in, and frequently they may have to have transfusions in addition to the dialysis treatment while they're down there. They will let you know how much they have dialyzed off, so that's a key thing to make note of in your report. Is they removed 2 liters today. They removed so much volume today, and usually hemodialysis nurses will make note of that, but you want to make sure that that's reported because that's giving you an idea of how successful that was. This just talks again about vascular access. These can get infected and have other symptoms of being clotted off and have problems. Those are things that you normally would notify the physician regarding, and in some cases it may be that you notify the dialysis unit team as well. You can also have thrombosis, stenosis in the vessels that are being used for these. Because of the pressure of this, some patients can develop aneurysms. They can have ischemia and heart failure from the pressure of this being done through their vascular system. Make sure that you're always watching these patients for hypotension because of that fluid. If you've had a lot of volume ever pulled off, what's their blood pressure coming back to you. It's not uncommon for them to be 80s over 50s, 90s over 50s on return from a dialysis treatment. Thus, they may have headaches, they may have nausea, vomiting, dizziness because of that. Sometimes experience muscle cramps or bleeding like nosebleeds, other things that are coming from being too anticoagulated. They call this when they're kind of off kilter post dialysis disequilibrium syndrome. They can develop infectious diseases because of this, including Hep B, C, and HIV. There is such a thing as peritoneal dialysis. Patients are taught to do this to themselves. You're not getting tested on that, but I just wanted to make you aware of that and show you some pictures of that. There are different methods for this to be done, but it's really where a rubber catheter is placed in the abdominal cavity and dialysate is put into the peritoneal cavity, and it dwells in there for a period of time and tries to pull off the extra fluid and pull off some of the items you want to be excreted with it. And here's a picture of a patient receiving this and doing this to himself at home. So a certain amount is infused, it's clamped, it's allowed to dwell in there for a period of time that the doctor has kind of predetermined, and then at the end of that time period, that is released into the bag below. And then that is how much came off is compared to how much they put in, and that's how much extra has been removed fluid-wise from their body. There's also a way to do this continuous peritoneal dialysis, and this is just kind of the setup and how that works. These are just some of the typical complications. Obviously, patients having this infused can develop peritonitis, pain at the site, can develop severe infections. Sometimes the flow of that dialysate doesn't go well because of having done it again and again and again. They can have leakage of it, and it's not staying in there and dwelling and doing what it's supposed to. So hopefully this has been helpful. I will now try to go and tape your exam review.